Welcome to the IMWG conference series coming to you today from Madrid in Spain. This is the venue for the IMWG Summit and also the upcoming European Hematology meetings here in Madrid, the EHA meeting. And I'm very, very pleased to welcome you. And with me today, I have Mariví Mateos from the University of Salamanca in Spain. Very pleased to welcome you again, Mariví.
Hello, thank you very much for the invitation to be here.
And Dr. Joseph Mikhael from the Mayo Clinic in Scottsdale, Arizona. And also welcome back to this conference series program.
Always happy to be here.
So we're very pleased to be able to report some recent findings and discuss those new findings along with a lot of exciting data that have been building up over the last 2 or 3 years. And so it's good to see what do these new abstracts and presentations mean related to all these new important studies that have been published and presented over 2 or 3 years, actually. So for today, we're going to talk about 6 topics. We're going to talk about imaging in 2017. We're going to talk about what is the future for frontline therapy. We have a pretty good idea about what might be the standard of care, but what is going to be the upcoming standard of care? A huge topic for the last 2 or 3 years has been MRD testing, and so we need to think about where are we with that and how will it guide. I've focused on clinical trials where I think the decisions need to start. And then to talk a little bit about where we are in terms of risk assessment, how much do we use risk assessment in our standard approach to treatment. Of all of the new therapies that we have come up with, which ones are really going to make it? Which ones will have a significant benefit such that they could be approved and really add significantly to improve patient outcomes? And with all of this new stuff happening, what is the impact of cost, and how do we really figure that into our thinking in terms of our protocols now, the costs now, but also thinking ahead to what will be the ultimate cost for the future? And so let's start with the ideal imaging in 2017. And so we have moved over the last few years with the help of Joe Mikhael from CRAB to the slim crab, and we've talked about the criteria that are necessary to diagnose myeloma early, 60% plasma cells, the light chain levels, and the MRI to give us that early decision making. And so we have this baseline testing table here where you have MGUS, and then you have the myeloma defining events. In addition to the 3 that you just saw, we also have some finer assessment of renal function, the creatinine clearance, which is a myeloma-defining event prior to the onset of true CRAB criteria. But in the implementation of these myeloma-defining events, where are we with the imaging part? Now, does this mean that we don't use X-rays anymore? We have learned that if you do CT, whole body low dose CT, that you can pick up at least 20% more lesions. And then also with MRI, you pick up more disease, and with PET CT scanning. And so the questions are, and maybe Mariví, you could comment first, because I know this was extremely important to you in your smoldering myeloma trial in terms of the imaging. So perhaps you could comment with your experience there.
Yeah, thanks, Brian, for the question, because I think that the evaluation of the bone disease is extremely important in the management of our newly diagnosed myeloma patients. And skeletal survey has been the standard evaluation, the standard assessment for the evaluation for more than 30 or 40 years. However, as you mentioned, we need 30% of bone loss to have a lytic lesion. And now we have more sensitive techniques like low-dose CT, PET CT, or even MRI for the evaluation of bone disease. So I think that we have to switch from X-ray to this new assessment. how to choose among low-dose CT, MRI, or PET-CT. So
Yes.
I think that from my personal point of view, I think that at the moment of diagnosis, the three techniques are available and are good techniques for the evaluation of bone disease. But you know that the International Myeloma Working Group update also the criteria for the evaluation of the response. So if we are thinking in the use of these imaging assessments for the evaluation of the response, for me the optimal way will be to use PET-CT.
Yes.
Because
Then you
MRI
have it-
is
then you-
able to detect lytic lesions at baseline, but during the follow-up, the predictive power of the MRI is much more lower in comparison with PET-CT.
But then you also need the baseline. Yes.
Yes. Yes, and also we have to realize that approximately up to 20% of the myeloma patients can be PET-CT negative. So we have to investigate more and more in the PET-CT using probably new markers to try to identify these 20% of the patients in which PET-CT can be negative. But definitely, I think that we have to move from the conventional X-ray to these new imaging assessments.
Now, do you want to comment about what happened with your screening in the smoldering situation?
Yeah, this is extremely important because so we conducted, as you know, a trial in smoldering in 2007 in which skeletal survey was the standard care for the evaluation of bone lesions. Now we have already completed the recruitment of our new trial also in the same patient population, high-risk smoldering myeloma patients. But now we decided to use PET-CT as screening, and 32 screening failures were so far reported.
Wow.
And these screening failures, most of them were new myeloma due to the detection of lytic lesions when we moved to PET-CT for the technique for the evaluation of lytic lesions. So clearly it represents a much more sensitive technique, and so we are going to be able to do the diagnosis of new myeloma.
Right. So huge educational point. So, what's your perspective on the imaging? What do you do? X-rays? Which testing do you use?
No, I think Marie said it very well. But actually, I still use X-rays up front for two reasons. One, because it can be done very quickly in the workup of a patient, and if it's positive, I still do agree that the PET scan or whichever you can use. We actually have a protocol using the low-dose CT, but we often will go straight to PET scan. Will not only help diagnostically, but as Marie said, will help you follow the patient later.
So that's important to have that baseline.
Absolutely. But the second reason is often, especially in patients who may have very severe bone disease, the X-ray paradoxically might be the best image if someone needs a surgical intervention. So we have patients who may have, particularly in the long bones, that may not be as beautifully seen in some of these imaging. I just had a patient a week and a half ago. We did that, and the orthopedic surgeon looked at the X-ray and said, no, we need to pin that. So I'd say that slim crab is not going to be so slim. It's getting a bit fatter here with more options. So I'm not sure if I'll call it chubby crab or what, but we'll find something to include these different modalities, because I think although the MRI in our diagnostic criteria is the one that's been validated with more than one focal lesion, I think with time we'll be able to incorporate these three different ones. Not to mention, looking a little bit ahead, it could be that PET MRI in the future, which is now something we're exploring, could even yet be another one. But I think the take-home message now is that the skeletal survey may be helpful to a certain degree, but another level of imaging is likely important for a baseline and for diagnosis.
Or maybe diffusion-weighted MRI, I don't know if you're able to do that, yes. And then the final point, which actually you touched on, is other testing. You mentioned that there are 20% who are PET negative. Do you have any thoughts about what would be a way to detect or look at those patients?
Probably using new tracers for the PET-CT, able to increase the number of patients in which the PET can be positive. Probably this is the way in which some groups are investigating.
Right.
And the PET MRI might be a part of that solution as well.
Yes.
I mean, that's still limited technology. Not very many centers have it, but it has that theoretical advantage of really combining the benefits of a PET CT-like scan as well as MRI into one.
Right. Okay.